physically accounted for and present, and he is ready to roll. So we're going to go ahead and get going. Dr. Staples is also joining us on the call, and so if she has stuff to add, she will add it. I'm still trying to get the chat box to work here, but so if you guys have questions, try to signal us, I guess. And away we go, Dr. Stoller.
Okay. So again, thank Dr. Staples for being here. She's certainly going to handle all the questions that have the pulmonary function test on them, because she can go real quick through those. All right, so let's look, and overall, I think as a group, y'all did pretty well in these groups of questions. So let's go with number one. And this is, of course, a kid with croup that you know, and the real treatment, the real question here is, how do you treat croup? And the thing is, he has no stridor, just so he has a barky cough, that's croup. The heliox would obviously be in a PICU situation. He has no shortness of breath, no fever. The albuterol obviously is for lower airway disease. The oral antibiotic would be not for a virus. So basically the real trick was to get it down between B and D. And I can understand, obviously we use nebulized racemic for croup, but if you have no stridor, then nebulized racemic can indicate, because remember, you can have a rebound from that. It's not that it's not a great drug for croup if you're in respiratory distress, but in general, the treatment of croup is hydration, control the fever, and cool mist therapy. Okay, so the answer here is, for this patient, the most appropriate therapy is cool mist. Now, the second question, it has a lot of little things to it, which I think you can go through, because remember, when you look at questions, if you look at answers that classically should go with something else that doesn't meet this vignette, and you know that that answer goes with something else, then that most likely is not the answer for the vignette, because the vignette doesn't fit the something else. For example, all right, so this is a 2-month-old. Now, what are some key words here? Uneventful vaginal delivery. Now, what would that be all about? Well, the classic would be, why is that there? Meaning the patient wasn't intubated. Because when you get into intubation, that's where you can get into some things like vocal cord paralysis. So the mere fact that uneventful vaginal delivery is there, that just says not intubated, hence not vocal cord paralysis. Okay? Now, if you look at remember we did this Tuesday, in the thoracic, expiratory stridor, out is in and is out, remember? And so then when you look at vascular ring, and to some degree, mostly tracheomalacia, you could argue is intrathoracic. Notice that we talk about the noise on inspiration, hence it has to be out of the thorax. Laryngomalacia is out of the thorax. So essentially, you should get it down between laryngeal web and laryngomalacia just based on that knowledge base. Then you come back up and you see it's a 2-month-old. And then laryngomalacia, which is the most common of those kind of things anyhow. And remember, that's what they want you to not miss, or the most common things. So if you get into a situation, and there's a question coming in a minute, which I think this will point out, where you're down to 2, and one is extremely rare, and the other one is much more common. On a general PEDS boards, not on a subspecialty boards, then I'm going to go with the most common answer if you get it down to 2. Okay, does that make sense? Just that approach makes sense?
The
Okay.
other key that I would put from this stem is the noise is louder with supplying is a very key point for laryngomalacia. So that in and of itself should include you as a different.
All right, good point.
Correct, because tracheomalacia is intrathoracic.
Remember, it's
So it should be
thoracic.
expiratory.
But as far as
It doesn't matter as much. What happens when you lay back is that kind of gets gravity against your larynx. And so you may also see softer when.
So again, please remember the out is in and in is out that we've all gone over many times. Now, number 3, a lot of you missed, and this is a classic X-ray. And basically, if you put chlamydia pneumonia, you really need to go back and read it, because you know chlamydia is a bilateral pneumonia. You know, it's kind of a honeycomb-looking X-ray. This would not be anything like that. This is a chest X-ray where obviously there's a push or pull going on. because you see your cardiac silhouette much more over to the right side. And you see this big kind of loosened area, round loosened area that is on the left. So the logic is it's probably pushing to the right instead of the right pulling it from the left. A pulmonary sequestration is a density in the left lower lobe, most likely. It looks like a bacterial pneumonia, a lobar lesion. There's no lobar lesion here. Now, actually there is. If you look at that left lower lobe, see that density that kind of extends down, that is going to be atelectasis, and that's because this particular part of the lung, which is lobar, congenital lobar emphysema, is going to be pushing the other parts of the left lung down. So you're going to end up with a little atelectasis in the left lower lobe. So in fairness to you, if you see that density that's above the diaphragm on the left, there is a density there. Now it's kind of a cylindrical density, if you will, as opposed to a strict lobar density. And I understand that pulmonary sequestration again occurs there, but it's the rest of the film, it's the push of the film, it's the abnormal volume of the film, with right being less than left, that pulls you away, no pun intended, from pulmonary sequestration. Diaphragmatic hernia, of course, there are no vowel sounds there. No vowel loops there. So basically, when you see this, your first thought is, well, this is round and kind of loosened, and it's a cyst. So I got it. So I can understand how you put a bronchogenic cyst. But a bronchogenic cyst is just sitting there. Okay? So it doesn't have air coming in and collecting air and getting bigger and bigger like an emphysematous lung would. Okay? So just a lucency in the parenchyma might be a bronchogenic cyst, or it can be other places anatomically, but it doesn't push or pull. It just sits there. The thing that pushes, or in this case, is a congenital lobar emphysema. This is a classic. You have to surgerize it. You take that lobe out, and everything's hunky-dory afterwards. Okay? But this is a classic film for congenital lobar emphysema.
I would also just say bronchogenic cysts tend to be from foregut malformations. They tend to be more mid-lung. Most commonly, we see that stuff from most of it, usually more mid-spinal. You're not going to see the shift.
Okay. Number 4. Now this one is, if you miss number 4, we got some work to do here, because this is kind of like, 9-month-old rhinorrhea, cough, wheezing. What more do you want? Okay. Of course, with the no fever, the bacteria come out of the strep pneumo and H flu come out. So you're back to the chlamydia again. And when does someone get chlamydia? Classically 6 weeks of age, not 9 months. So the age doesn't match. Once again, incorporating the age into the question. So you're really down, in my mind, to RSV, which this is the classic of that all of you know, versus Bordetella pertussis. And I would agree. I guess you could catch me on that. But I would argue that the stem of the question would have said unimmunized. That would have set you up a little bit more for that being the potential answer, even though I could argue that some of the symptoms, especially the rhinorrhea, would push you more to an upper airway and lower airway, or go RSV, whereas pertussis is more lower airway, trachea, lower airway, not the rhinorrhea, if that makes sense. So the answer is RSV. Remember the chlamydia? This is a classic pattern recognizer. What should have been there when they talk about the cough, if that would have been the answer? It's a staccato cough. So if I am reading a question and I see staccato cough, I don't care what the question is. The answer is chlamydia, because that's your pattern recognizer. Now, they're not going to do that as much as they used to, but that's just a pattern recognizer. Okay? Number 5, here's a kid with classic fever, bacterial pneumonia, not oxygenation. Oxygenation is not a problem. Respirations are not a problem. She's got a classic vocal crackles, decreased percussion, left lower lobe. She's got a bacterial pneumonia. You know how to treat bacterial pneumonia, outpatient with high dose amoxicillin. Okay? And then the next question says, because they should be better in 19 hours. The classic average or the first of when they start giving it is 19 hours with a, now this is where the adjective comes in, complicated versus uncomplicated. So when you see her there, she would have been an uncomplicated pneumonia with that presentation. High dose amoxicillin should be better start being better in 19 hours. Okay. Obviously, she comes back 2 days. She's not better. She's worse. So now you've got a complicated pneumonia. And so now you're going to have to say, why is it? And then you look at those answers. And since you are connecting the dots with the strep pneumonia, a complication is an empyema, which is the right answer. Now, if you look at the inappropriate antimicrobial therapy for strep pneumonia with high dose amoxicillin, okay, you could find a resistant pneumo that could be out there. But now you're moving away from the classic of what's the most logical thing. Okay? So the answer is development of an impairment.
So the other thing that I would add, just from a test taking strategy there, guys, is there's no way for you to know if it's inappropriate or not. If they give you the sensitivities and specificities, then you can know, but there's absolutely no way you can know. You can make an assumption, but you're not making assumptions when you're taking tests. They're giving you information, you're using the information that you have.
Fair enough. Number 7. All right, now here's the key right off the bat. It's a 4-month-old Caucasian born to a healthy mother. The fact that the mother's healthy, you come down to HIV, and that's going to fall off the table. I know it's possible that the mother has HIV and can be, quote, healthy. I know, therefore, the baby could get it and start having trouble. But the fact that they put healthy in it, why would they have said healthy? They're trying to say healthy so that you can get HIV off the list. That just is not going to be on the list with that one word. And then you read the rest of the question. Basically, you would have gotten this question. I mean, then the product syndrome, 4-month-old, please. And then the isomaltase sucrase, that would be diarrhea. Now, part of this question is for you to know that breastfed babies poop every time they feed, meaning she doesn't have diarrhea. So you have to move away from your diarrhea part of this question because sucrase isomaltase and acrodermatitis enteropathica are diarrhea. Okay? Not to mention that acrodermatitis enteropathica starts when you go from breastfeeding to regular milk. Because that would have, when I first read this question and I was doing it, I thought, oh, this is good. It's zinc deficiency acrodermatitis. And then I went, but now wait a minute, the infant is breastfeeding. And there was the reason that doesn't fit. So basically, you're by default left over with the only answer that could be there, which is cystic fibrosis. Now, you should say, well, wait a minute, Dr. Stallworth, why does the CF got a hemoglobin of 7.2? Why is the more skin erosions around the mouth and hands and feet? Okay, good question. All right, so remember, what is the classic vitamin that's associated deficiency that's going to be associated with an anemia and that's going to be associated with skin findings, in addition to some other things, but that's your vitamin E deficiency. And remember, A, D, E, K, fat-soluble vitamins, CFs have trouble with that. That's how you have to connect those dots to pull the answer of CF if you didn't understand how it connected. So you could look at this in a couple of ways by being very, very erudite and putting all that together, or go in the back door and say, well, it's not that, or that because of what I just said, hence the only answer left is cystic fibrosis. Okay? And notice they say Caucasian. Now, we all know that it can occur in the black population, but why did they say Caucasian? Why did they say healthy mother? I mean, words like that you look at, and a good test taker will look at that and say, well, they didn't have to say that. But because they did say that word, it has to fit the answer. You see, that's so you just can't skip over words. You have to look at the words and be sure you're reading them and letting them help you.
So Mason would like to know why breastfeeding took you away from acrodermatitis.
Because acrodermatitis doesn't occur with breastfed babies. It occurs when you move to the classic. Apparently there's some zinc in breast milk. And you remember acrodermatitis enteropathica is zinc deficiency. It is an autosomal recessive disease, you can get it. But the breast milk, I think, apparently has some zinc in it or enough so that the child doesn't have the symptoms as much. It's when when they're weaned off the breast and they're not getting supplemented with zinc, and that's when the symptoms. Okay. All right, number 8, in the previous question. All right, now this is, I'll let Dr. Staples clue in here. But really, the real trick on this question is long-term. So you've got to look at a CF that we just decided had CF. And what are the long-term? Well, you do know the Pseudomonas business. That's always bad. And then you got to decide, well, is it just that, or is it A, B, and C, or A and C, or because A is all of those. So you just don't spend much time because you know A is going to be part of the answer. And so then you just look at long-term prognosis. And Heather, you want to comment on that?
Yeah. So the research that's been done on long-term outcomes in these patients show that colonization with Pseudomonas obviously impacts lung function. And so negative impact on lung function is an increase in morbidity and mortality. The other thing that is very significant is nutrition in these patients. And so actually this information came out of Canada even before we were doing it in the US, showing that patients whose BMI is above the 50th percentile actually have better lung function and better long-term outcomes. So that's why we follow these patients closely. That's why you get such aggressive dietary because that significantly impacts how their outcomes are. And liver disease, obviously, but that is not as closely related to outcomes as Pseudomonas infection and nutrition.
And remember that the liver disease of CF, of the is biliary cirrhosis, is the classic cancer that goes with that.
That's what causes the most morbidity. You can have hepatosteatosis and you can have gallbladder issues. But the most significant one that causes them to require liver transplant is cirrhosis.
Right. Yeah. And then I think with the cirrhosis, remember if you get cirrhotic, your transaminases go down. They don't go up. You see what I'm saying? So they elevated. Okay.
Sorry, my voice is
Okay. Number 9. This is a 10-year-old, 9 months old, Mr. Brad. Okay. Now his cough is non-productive, right? And so the CF is a productive cough. So that comes out. Just using that word, non-productive. It's also got rhinorrhea, itchy, watery eyes. I mean, they're putting a lot of things together to help you with allergic disease. And if you look at the 2 that are, that'd be chronic asthma, potentially chronic sinusitis, right? Okay? But when you get down to the pulmonary function test, which again, Dr. Staples mentioned, and he improves this albuterol, that moves you away from the chronic sinusitis, hence makes the answer to chronic asthma.
Also, I would point out, if you've rotated with us, you have learned this, but a change in FEV1 by 12% is considered a significant change after bronchodilator in FEV1. For your FEF 25 to 75%, an increase by 25% is considered significant, and that can be diagnostic for asthma in the setting of these other symptoms. So those numbers themselves are also pretty important if you remember and are aware of those.
Okay, number 10, now this is just, don't make this be hard. The most likely with an inhaled steroid is dysphonia. I mean, you just think logically. Don't make that be something more. I know you can have those other side effects, but the most likely one with something you're inhaling into your lungs is going to be dysphonia. Okay? Number 11, this is a 72-day dose of 25 weeker, and of course on oxygen, caffeine, or active.
Hey, everybody, can you hear Star now? I'm sorry, there's just not enough room in this space for us to get together and hear everybody. Can you guys hear him now?
No, it's kind of hard to hear me.
It's kind of hard to hear me.
Where's the microphone?
Okay, can you hear me better here?
Yes.
Okay, so you've got to be straight on to the microphone is the deal. Okay, so this 25 weeker, who obviously is on oxygen and has this caffeine for apnea of prematurity, 25 weeker, is now 72 days, easily could have what problem? Bronchopulmonary dysplasia, right? I mean, easily. It doesn't say he does. I'm not saying he does. I'm saying he easily could. But that's not the question. But let's just admit that as we're thinking through this. So of the past 4 days, he's had oxygen desaturations, and of course, his x-ray is fine and his counts are fine. The most likely diagnosis for these changes is, okay, well, necrotized enterocolitis, no. Ureaplasma, remember that's when they get in the vaginal coming out, so that's going to be earlier than 72 days if they're going to have that. And that's your equivalent to your mycoplasma in the older kid. I'm not saying a 70-day couldn't have it, but classically they're going to be a little bit younger because they get it when they come through the birth canal. The anemia, okay, you could say, but they say the complete blood count is unchanged. Hence, it's not anemia. That would not be fair if they said, well, it's been 4 and it's still 4 and here we are or something. No. So you're down to the pulmonary hypertension or the GE reflux. So we have the expert in pulmonary hypertension here, Dr. Staples, so take it away.
Well, when you get down to those 2 questions, I'd say the kid's being fed by a TP tube. So you could still have GE reflux, but it's mostly going to be gastric contents and not really feeds at that point. But pulmonary hypertension can rear its head after the baby seems to have somewhat improved. It can be very significant. You have to think about how the lungs are developed at 25 weeks. They don't have fully developed alveoli at that point, and the alveoli is where gas exchange occurs. And so over time, as you're stressing this baby and weaning hits support, you're going to start seeing higher and higher pressures in the lungs. And that's why sometimes you'll get a baby here on a 1/4 of a liter who seems to be maybe moving in the right direction that all of a sudden gets significantly worse. And that's not an uncommon presentation for pulmonary hypertension.
Okay, number 12, the key word here is bilateral. When you see the bilateral, tension pneumothorax, hemothorax, normal pulmonary findings, paralysis of the left atrium, they're all unilateral. So just by default, read bilateral and it's pulmonary edema. And there are some other things in there that could help you, but that's the key word there. It's just not skipping over the bilaterality. 13, Dr. Staples will talk about the pulmonary functions.
Is there a picture? Okay. So with any muscular dystrophy, the one thing that you always want to think of is their risk for restrictive lung disease. So they don't have as much movement of their chest wall and therefore their lungs. So when you have restrictive lung disease, you're going to have a decrease in both your forced vital capacity, the FVC, as well as your FEV1, the forced expiratory volume in 1 second. But they're going to be decreased in equal relationship to each other. So your FVC and your FEV1 should be low and your ratio should be normal. So that immediately gives you A as your answer because both your FVC and FEV1 are low and your ratio is 99%. Anytime your ratio is below 80%, that's more consistent with obstruction. So that immediately gets rid of C, D, and E. And then for B, you have a normal FVC and FEV1, so that's not restricted. And this is a kid who has progressive scoliosis and limited upper extremity use, so you know he's got issues with restriction in his lungs just because of the scoliosis itself.
Okay, number 14, you've got the nighttime cough. You've got coughing that occurs with vigorous activity. You know, everything that wheezes is not asthma, and asthma has many presentations that don't have to necessarily be wheezing, but he gets a URI, the cough worsens, there is no nasal discharge, so allergic rhinitis comes out. Your atypical pneumonia, well, okay, he's had the cough for 6 months. Gastroesophageal reflux, okay, we might bite. Sinusitis in an 18-month-old, I don't think so. Across the board. So you're kind of down between asthma and GE reflux, okay? And again, for the kid to have GE reflux all of a sudden at 12 months without trouble before would be atypical for the natural history of that disease. And the vigorous activity pushes you into exercise-induced, if you will, and you all know exercise-induced asthma, and hence of those answers, that is going to be the best one you've got. Okay, and it just says most likely, it doesn't say definite. Okay, 15, 2 quick words. You see abrupt cough, it's a foreign body, just move on. I mean, I just don't even play the game there. And so it's an abrupt cough, and so you want a chest x-ray. What are you going to see? You're going to see maybe something like I showed you on the congenital lobar emphysema. depending on if you have a ball valve effect of that foreign body, letting air in and it can't come out and gets bigger and bigger until you get a tension in the thorax, or if it just clogs the airway, the right main stem, you'll just get atelectasis of that lung. But the point is, the volumes are not the same. Foreign body, unequal. I just went over this on Tuesday. When you look at the lungs, you have to look at volume. You know the right's a little less than the left. You look at total volume, but when you see significant discrepancy of volume, especially in something, that's what you would see here with the chest X-ray for the answer being a foreign body. Okay. 16, this is, as you go through this, the infant has trouble right off that. The key word is scaphoid abdomen. You know that's a diaphragmatic hernia, so the Bible's going to be in the left because the left is more common than the right, and etc. Now, the other question that's not in here, but you have to know, long term, if they said this, what long term might you think? What is the answer? Pulmonary hypertension. Okay, this is the diaphragmatic hernias are the ones that even after they're that's the long term, not the short term. The long term is a diaphragmatic hernia. Okay, if you want to go in the back door on this question, then you should know inflation with bilateral patchy infiltrates. What is that? Meconium. What's normal lung volume to a polycystic pulmonary? It's probably some congenital heart disease. What's overinflation of period of time? Transit to get a newborn. What's under hyaline membrane disease? I mean, you could go the other way, and that's what I was saying a while ago. If you have something that classically meets the criteria that are not there, then that's more than likely not the right answer. And then you can almost get it by default. Okay. 17, please note the maximal impulse displaced to the right. That's going to be the key here. Okay, but if you wanted to go the other way, well, X-linked Britons and severe combined in a 4-year-old would be dead if you hadn't diagnosed it by now, in general. And I know they're, you know, if he was getting treatment, that'd be different, but they don't talk anything about him getting treatment or anything. So they're out. HIV, well, he's growing okay. I mean, there's just, you know, you kind of go, well, all right, I guess he could, but there's nothing in there that would point you toward HIV. So basically, you're down to CF and primary cilia dyskinesia. And so you get into the primary cilia dyskinesia, associate that with the dextrocardia, push the maximum impulse to the right, and the answer is Cartaginer syndrome as opposed to CF. And the other thing is, well, his height and weight are not the best, but he's not below the 5th percentile that you might expect with a 4-year-old who's been untreated for cystic fibrosis. Okay. The other thing is mild clubbing. Okay. CF generally has more than mild, but I agree. He's only 4, and it's the spectrum of disease, but it's that maximum impulse that pushes you to the right answer.
And I think you'd be unlikely to see frelent rhinorrhea in a stem for cystic fibrosis.
Okay, but the nasal polyps you could see.
Correct.
Okay. 18. Okay, this is a 5-year-old acute asthma. He's gotten multiple nebulizers. His respirator, his heart. The most likely reason for the decrease in pulse ox. Now, again, this should get down to 2 things. It should really get, I mean, why would he have bacterial pneumonia? He has no fever. Unrecognized cardiac disease at 5? I don't think so, you know, relative to this presentation. Foreign body within the airway has moved. Okay. Well, okay, I'll bite. I guess we might have to consider that, but goodness, you're constructing, it had to move in a reason to make this happen would be a little bit weird. The damaged pulse ox, well, maybe it is. I mean, how do I know it isn't? But the classic thing in a child with asthma, you and I both know that they have VQ mismatches, okay? And so even though you may open up something else may become atelectatic, but you know that asthma is a classic thing with a VQ mismatch. So the ventilation and perfusion mismatching is going to be your answer. The 19, and I'll let Dr. Staples, this is where you just got to know, based on the signs and symptoms, how do you categorize your asthmatic? And I have to look, just because I don't do outpatient, I would always, like a question like this, I have to look at this before I go in the test. I just have to look at it refresh my memory, because it's gonna be on there, because they're gonna ask you, they're gonna expect you to put together what category, so that then you'll know what the treatment strategy is going to be.
Yeah, so I agree with Dr. Stallworth. Honestly, in practice, I don't have these charts out in front of me. It's a little bit of a gestalt decision too, but definitely you want to look at the number of symptoms per week, the nighttime awakenings, the frequency of need for albuterol, and then if they're old enough, and this child is, you also want to look at their pulmonary function testing. So those are the key points that you want to look at when you're determining asthma severity.
Okay, number 20 is falling off the log. Rhinovirus is the most common cause of illnesses in kids, so that's going to be E. 21.
The other thing, guys, that I would just make mention of when it comes to testing in general, so you guys have all heard about the GINA guidelines now for diagnosis and management of asthma. You have to be a little bit careful in applying information that hasn't made it into a test yet. So those are really recent updates. You guys have a lot more clinical knowledge than what has made it into a test. You always have to give things a few years before they start making it into tests. So just be aware of that. While you might know something now and it may be different, you might have to think about, well, how does this apply to a couple of years back?
And remember too, the GINA guidelines are one of the two guidelines. The NHLBI guidelines have not been updated to include the new use of a combination inhaler as rescue. So just be aware there are two different sets of guidelines. Most likely the test is going to be based off the NHLBI and not GINA.
Number 21, monthly injections for RSV in this kid. Of the following, which diagnosis is most appropriate to consider such treatment in the 6-month-old? This is either you know who gets the medication or who doesn't get it, right? And so of the following, which diagnosis is most appropriate to consider? That would be chronic lung disease of BPD, right? 22. Now, when you see anything like mineral spirits or gasoline or viscous and cough, then by definition, what they're going for is he's aspirated. I don't care if he's in no trouble. I don't care if his x-ray right now looks fine. He's coughing, he's aspirated. And then that has a timeline. And so the timeline is the 24-hour, sometimes 48-hour timeline. So anybody like that, when you see them coughing, they're going to be admitted, but you got to be prepared for the chemical pneumonitis that's coming down the track. But the real trick is just know that cough and gasoline, and they'll say the kid looks fine because the kid is fine, because the trouble's going to come in about 6 hours. Okay, so just anytime. If they said no cough, now that'd be different. Then I don't know. We could ask the specialist what they would do, but that would be the real essence here. Is they're not going to do that because they want you to pick up on the fact that the x-ray's fine, the kid's fine, but the cough is associated with he's aspirated this and it can get bad. We've seen it.
Yeah, so Mason wants to know, are we not worried about the swelling of his airway with the spirits? With ingestion. And Mason, what you're doing there is you're extrapolating out, right? Don't
Right.
give
See, he's trying to add to it. Yeah.
If they told you he was insignificant.
He had Strider.
Strider, then
There you go.
But he doesn't yet. So that's where the admission and observation comes in. He may.
Right. I mean, if they went on, instead of no other physical findings, they said on physical findings he had Strider, then you would be caught on giving the steroids or not. Now, to be honest, you're going to have to look up the evidence-based medicine for that, because the steroids in that kind, you'd probably do it, and I agree with you, but it depends on the other answers as to what's there. But in this case, no, that's why there are no other findings, and steroids are not used for prophylaxis of a chemical pneumonitis. No. We do not do that. So you can't use the steroids for that. And the fact that it doesn't have Strider pushes you away. But that could be coming once again while you hospitalize it, because that could be now an upper airway problem that's coming and you just have to wait on that. 23, I went over this on Tuesday essentially, but this is a 6-year-old. And to be honest, I might have made him a little younger, but not much. He's got high fever. He's toxic. So this is something bad. Now he's got, again, there's that word bilateral. Now it's bronchi bronchi, upper airway sounds, but they're bilateral, they're not unilateral. So if you think about it, bilaterality would be, a foreign body would be unilateral in a perfect world. Of course, croup, basic laryngotracheal bronchitis, the 104 toxic, probably not, would go with that. Epiglottitis, they say he lies flat, so that's out. You know, I never know what bronchitis really is, so I have to let that go. But this is going to be a classic cough. You're thinking about coughing, you're thinking about high fever. This is your classic bacterial tracheitis. And remember, on the film, that's when you look at it, and you may still have what looks like a steeple sign, but when you look at that trachea, it's ragged. It's got ragged edges. Remember on an X-ray, if you're trying to tell the difference between a pericardial effusion and cardiomegaly, you look at the edge, and in a pericardial effusion, that edge of that big cardiac silhouette is just a little ratty. That's pericardial. If it's not ratty, then he's probably got a big heart. Okay, so you look at things and you look at them with a jaundiced eye of, let me be sure it's not that or that. And that's just a little extra I throw in. Okay, moving right along.
Can I just make a quick comment? I know that's very easy to just look over bronchitis, and typically in these tests you should. Let me just point out, there is an entity called protracted bacterial bronchitis. It is 4 weeks of daily wet cough. It is not a 2-day history of cough and fever. Just be aware that exists, but don't get caught up in this type of scenario thinking that's what the patient has.
Well, I appreciate that, and that would be getting you a little bit into the subspecialty world,
Yeah.
more than you knowing viral croup versus bacterial tracheitis. 24-week, number 24, a 3-week-old with coughing while feeding. Now, the key word here is diagnostic. What test is diagnostic? Because honestly, if you got this down, you probably should have gotten into laryngoscopy or barium swallow, one of the two, because the EKG, no, the sweat test, no. I mean, and he has no stridor at rest. Hence, that's why that lateral neck or the radiograph of the neck would come out, AP or lateral. So I understand that laryngoscopy or laryngoscope evaluation can be done, and it will help you many times say, yes, this looks like it's compatible with, but the question is, what is the most helpful diagnostic study? And so the diagnostic study is to look at a barium swallow, to look at function, and to look at anatomy, to see what's going on here with this kid who has stridor, cough, and wheezing after feeding. And so vascular rings could be in there, of course, reflux can be in there, or where they swallowing difficulty, so you have to have an active test. You have to have something in action. A barium swallow is in action. Okay, test where you're looking at function, mobility, if you will. So the answer is barium swallow. But I can understand how you would have gotten caught on laryngoscopy, but look at the word diagnostic, not what is a test that's most compatible with? That's not the question. The question is, what's the diagnostic test? Now, had they had an MRI up there of the chest, I might have been a little bit funky on that. I wouldn't know, because that can be really helpful for a vascular ring, a coar, some other things, but it's not there. Okay, 25, this is just a straightforward database. You either know it or you don't. So what is not associated with asthma? And you know the allergic shiners or the obesity is the eczema, the allergy. The pulmonary function test that does not reverse, it's a double negative on that question, so you have to kind of read it. But Dr. Staples, you want to comment on clubbing and asthma?
Right. So just on the airway obstruction that does not reverse. So we've talked about reversibility when we're diagnostically testing with TFTs for asthma. Chronic asthma with chronic airway obstruction can eventually lead to a lack of reversal of bronchodilator. Clubbing does not really occur in asthma. That's a consequence of prolonged hypoxemia over time. That's not typically what we see in asthma. That would be very rare, unless it's somebody who is got some other complicating issues. So clubbing and asthma, I would not really ever put this together.
But remember, clubbing is kind of funky too, because it can be seen in Crohn's disease, it can be idiopathic, it can be seen, so it's a kind of a funky thing. So this question has limits, but there you go. All right, 26. This is just knowing basic genetics of CF. And, it doesn't matter how many children you have, each child is a 1 out of 4, right, of your classic Delta 508, correct? Okay. So that answer is C. 27, notice the child is born at term. So what does at term? That would mean that the baby wasn't intubated, more than likely. It doesn't say there's any reason for until the baby has some trouble and has to be intubated for the Erb's palsy. So this says, when is the weaning of the ventilator possible respiratory complications? Well, the real trick here is not the Erb's palsy, and I got caught on this because I was trying to think, okay, wait a minute, what's the subject? Go through the brachial plexus, go through all the anatomy. The real thing here is prolonged intubation. That's really what they're asking you on this question. So if you think about prolonged intubation, you could have aspiration because of vocal cord paralysis. You could have stridor, obviously, but BPD is a lung thing, right? And since the baby is at term, BPD is classical. Yes, there's Wilson-Nickedy, which is a syndrome of term babies with bronchial, but that's getting way outside of the box here. Your classic BPD is going to be a premature baby who's been on ventilation, oxygen for time, blah, blah, blah. Hence, the answer is going to be A and C. Aspiration because of the potential vocal cord paralysis, stridor because, that tube's been in there, you have granulation tissue, and you get that. So that's the answer. 28. Okay, and this is a kid with, I think, exercise induced, and you know that he would use an albuterol inhaler before the exercise. Pretty straightforward. 29, this is the obese kid who's got trouble sleeping, and you can read that, and you know that you're going to have to do a sleep study to see whether he's got central problems or obstructive sleep apnea. We all know that a TNA doesn't necessarily cure it, right?
Thank you, Alyssa.
Thank you, Alyssa. Back. There you go. That's going to be the answer on the test to try to identify what's going on. And the key word here, of course, is this BMI of 29. 30, here's another one. Anybody with a burn.
Scott wants to know, do you not start oxygen therapy before the sleep study can be done?
No,
No.
because you are at high risk for hypoventilation, which would be an elevation of your CO2 during sleep. And the oxygen would mask that and actually can make things a little more dangerous. So absolutely do not start oxygen unless you've done the sleep study and you know they're not hypoventilating.
Remember, that's your Pickwickian syndrome. Remember they're driven by PCO2s to breathe.
Mm-hmm.
And so you give them oxygen, well, then they'll just stop breathing on you. So that's the Pickwickian. What author, Alyssa, what author is that alluding to, Pickwickian syndrome? Come on, let's go into literature. You know how I love you. Oh, that's a good one. No, April. Come on. Oh, my word. Y'all need to read some Charles Dickens. Read Charles Dickens, the Pickwickian Papers, and all that stuff.
Oh, they're referred to in Little Women.
Yes.
Another question. So Kelsey wants to know, do you not treat the stage 2 hypertension in the office while you schedule this?
Well, now that's a good question. I got you. Treatment with antihypertensive. I think that's a very good question, and I would agree that that has merit. Okay, and if you put that, I can buy that. So I would agree that that is a reasonable answer to that question. I cannot disagree with that based on that one pressure that they give you. So I think that's a reasonable answer. A lot of these are now the new recommendations that are coming out relative to this question. You know what I'm saying? Again, trying to look at the recommendations of questions that are 2 and 3 years old, if you will. But I would agree. I think that's very fair.
So Kelsey, the thing that I would have you think a little bit about is what's the underlying unified diagnosis for this patient? Sleep apnea, obstructive sleep apnea. And while you can treat the hypertension, you're taking care of one of the side effects of it. You treat the obesity as well, right, by referral to weight loss clinic. And so there are things that you can do to manage some of those underlying diseases, but for confirmation of the unifying diagnosis, it's the PS2.
that's what they go over, but I understand, Kelsey, what you're saying, because the way the question goes, the best next step. So the next step would say, well, let's put him on a medicine, because we're not just gonna have a polysomnography in the next 2 seconds. So I hear what you're saying. 30, ED, again, any burn, you always worry about, the airway swelling. And so it's going to be more elective intubation rather than any of these other things. And steroids, once again, with a burn, you got the side effects of the steroids setting up for infection and all that stuff. I know that they're probably going to get broad spectrum antibiotics to cover. I know all those other things, but the most appropriate first step is you've got to control the airway. You know it's going to swell with edema and inflammation, and so you're going to intubate. And that's, again, that we could argue that this is a classic question, that they are being sure you understand the consequences of inhalation burn. 31, we can read this whole thing. The trick is left lower lobe, decreased breath sounds, dullness to percussion. That's a low bar density. We're giving you everything that says a low bar density. Now, there are no crackles or wheezes, so you're kind of moving against necessarily a bacterial pneumonia or in a low bar density there, or, because the kids had this bacterial pneumonia. I understand that, but at this point, the real trick is, why does he keep having a left lower lobe pneumonia? That's the bottom line. And you go through all this other stuff. And the real trick to this is, well, I've got to know what the diagnosis is to get the answer right. If you don't know what the diagnosis is, then there are lots of things you could do, of which are on here, but that's really not the essence of the question. It's what is likely to reveal the diagnosis. Well, you've got to know what the diagnosis is. Then you go back and say, what is the test that gives me that diagnosis? And so the diagnosis, this is a pulmonary sequestration. The diagnosis of that is a CT scan, okay? Now, I'm not saying that they don't have VQ mismatches and a ventilation perfusion scan couldn't be there, but it won't be diagnostic. See, it'll tell you that it's a VQ mismatch, but the question is the diagnosis. You see, you got to read the words. You've got to read what are they asking. So I hope you see the difference, because the VQ scan would be abnormal. I got that. But that's just going to tell you it's abnormal. It doesn't tell you what it is. The CT scan will tell you what it is. Okay? And the last question is an infant with CF. Therefore, it's just basically, it's pancreatic insufficiency. What are your basic pancreatic insufficiencies? Are your proteins and your fats, not your carbohydrates. That's not a problem. So when you look at these answers, the sucrose and lactose come off because they really don't have an endocrine pancreas. I know as they get older, 10% can have endocrine, but they are exocrine pancreatic dysfunction. So the sugars come off. The high B, okay, that's a vitamin, maybe he needs it, but again, you're looking at fat-soluble vitamins, A, D, E, K. B is not one, hence not the right answer. So you're basically down to medium chain triglycerides or soy protein. And really, since they have trouble even with soy protein, basically with the enzymes, that you're going to give a very elemental formula. And so the elemental formula would be your MCTs. Those are your elemental fats. Your basic amino acids would be your basic protein if you had to go that far. Okay? So the best formula would be MCTs. All right, so I hope that's helped. Anybody have any questions? We did finish ahead of time, which is good. Anyone have any questions? Get it down, Ray. Y'all have any questions? Does that make sense? Okay, I'm almost finished with the next one, because the next one's coming up December 10th. It's rheum, ortho, and musculoskeletal. Okay, so hopefully we'll get that done soon. And then I think we'll have a little break, and then Dr. Carney informed me we're going to have this in-house test in January. And so there will be some hopeful abilities for us to not only help you look at other areas of education, but try to help us evaluate whether we're learning and these are doing anything for you. Anything else, Dr. Carney?
The only thing that I would say, you guys, that I think this test really helped to hopefully let you guys realize a little bit is that some test questions really try to use your ability to pattern recognize and anchor on things and know more than what they want you to know against yourself. And so sometimes when you pattern recognize something like no drooling, you automatically rule out an answer which is actually just a distractor for you. There are other pieces of information that go along with the diagnosis that might lead you there. And certainly, like Kelsey was just pointing out, you guys recognize that that's stage 2 hypertension and you want to take care of that, and you want to manage that, but that's because you guys know enough. And then a lot of times, test questions will do that. They'll use your own knowledge to make the test harder for you. And sometimes you just have to take the information that's presented and say, what are they really asking me here, and move through it now.
Okay.
All right, thanks, guys.
All right, thanks, Dr. Staples. Appreciate it.
All right, John, how did you do?